Resistant hypertension is not an uncommon problem, and unfortunately, with the aging population and obesity, it may not disappear anytime soon. So it's really important that in the December 3rd issue of JACC, there is a state-of-the-art paper on an international expert consensus statement on percutaneous transluminal renal denervation for the treatment of resistant hypertension. And I am with Dr. Krishna Rocha-Singh, Prairie Vascular Institute, back in my neck of the woods, St. John's Hospital in Springfield, Illinois. Now, at the very beginning, can we do something? Can we talk about the fact that resistant hypertension is just not hard to treat hypertension, or people who are resistant to actually taking their treatment? Yes. There is a specific definition to what is resistant hypertension, correct?
That's correct. I mean, the consensus documents that represent key opinion leader opinion suggest that resistant hypertension are those people who have an office blood pressure greater than 140 while on 3 medications of maximum tolerable doses, one of which ideally is a diuretic. So that sets the baseline, the ground floor of resistant hypertension. I think what's really important to understand, and what has been lost in a lot of discussions, is that the trials that they exist now don't look at just resistant hypertension. They look at severe treatment-resistant hypertension. So what's happened is we've morphed this designation of resistant hypertension into categories where now we have moderate treatment-resistant hypertension and severe treatment-resistant hypertension. And even when you classify severe treatment-resistant hypertension, we look at that as 160 on 3 medications, one's hopefully a diuretic. But when you start looking at the patients that are actually put into the trial, specifically Simplicity 1, 2, and 3, the mean blood pressure is not 160. It's between 178 and 180. So these are severe treatment-resistant hypertensive patients. And of course, this means that the applicability of the therapy to the general population has to be discussed.
Well, the reason I brought that up is 1 year ago at the ESC meeting, there was a paper presented that showed that 1/3, 33% of the people who were referred for renal denervation really did not have resistant hypertension. They may have had white coat hypertension. They were not on optimal levels of drugs, which was most of them. Yes. I mean, that's a little alarming. So we need to make sure up front that you have a resistant hypertension patient in front of you that you're considering referring.
That's correct. So you've made several important points. Your comments, I think, reflect back on the inertia that exists in the treatment of these patients by doctors and specialists, the lack of sometimes compliance and persistence on the patients to comply with their medications and take them over time.
Right.
When you start putting them into a clinical trial, whereby they are, if you will, watched very closely with regards to, are you taking your medications, are you doing home blood pressure monitoring and so forth, it's amazing. The collateral benefit from this is that we are now actually bringing this issue to the forefront in front of the patients and the doctors and saying, okay, you come in and you think you really have resistant hypertension, we're going to actually treat you. And the actual raise all boats part of this is that we can actually treat these patients because they become part of a clinical trial. They failed to meet the entry criteria, but the good part is they're now controlled.
Right, which is really good.
Yes.
So before we talk about specifics of the consensus statement, give me the background of it first, this new consensus statement published in JACC.
Yes, I was very proud to be part of an international consensus statement that was in the works for over a year under the supreme direction of Dr. Marcus Schleich, a nephrologist from Australia. And really it brought together doctors from all over the world, primarily from Europe and Australia, several hypertension specialists and endovascular specialists as myself, to put together and synthesize the data as it exists at the time. And we made some and Dr. Schleich and all of us made some very fundamental, I would say almost essentially obvious statements. One, that this is a problem. And we need to start addressing this problem as physicians, as administrators, as stakeholders in the care of these patients. Number two, if you select the appropriate patient, there is good evidence to suggest that you can anticipate that these patients will respond within 6 to 12 months in a predictable manner, understanding that a certain percentage of those patients will, as we call, not respond ideally. We know that it's safe, which is very, very important from 2 points of view. One, that there are no deleterious effects at this point in time that we can discern with regards to renal function or dysfunction progression. And the safety issue with regards to applying RF energy to the intimal surface of a renal artery, that too looks at this point in time to be very safe. The safety issue comes from the fact that we have to put a 6 French sheath in a common femoral artery into a patient, which is something that I think all doctors understand and accept as an issue. And the fourth point here, which I think is most fascinating, is that there may be what I call collateral benefits in patients with treatment-resistant hypertensive who, by the way, have diabetes, and by the way, are obese and have obstructive sleep apnea. And that has actually created a groundswell of interest in moving forward and exploring other indications that come under the umbrella of patients who have hypersympathetic tone, whether they be atrial ventricular arrhythmias, where they have renal dysfunction or end-stage renal disease. So as you can imagine, there's a lot of excitement from doctors all over the world in dealing with these problems that heretofore we really didn't have a good way of addressing.
And the consensus statement really underscores the fact that you're trying to learn from real-life lessons and then put them together into a document.
Absolutely. You know, any well-designed trial will have and be able to define the sweet spot, if you will, the ideal patient that will benefit from both an effective point of view and a safety point of view. And we understand that not everyone will benefit, and that is just as important in defining that population as defining the population that will respond. And I think simplicity 1, 2, and 3, and we are very much awaiting at the ACC in Washington, D.C., a little plug.
Thank you.
The announcement of that primary endpoint in Washington, D.C., which I think will reverberate throughout the world and this very important field.
Well, I'm looking forward to that because I'll be at the ACC meeting, as you might imagine. And I do recommend that between now and then, if you have patients with resistant hypertension and you're thinking of renal denervation as a possible treatment, check the December 3rd issue of JACC. And the state-of-the-art paper is an international expert consensus statement. And Dr. Rocha-Singh is one of the co-authors of this document for CardioSource World News. I'm Rick McGuire.